Afternoon. Good afternoon, ladies and gentlemen. My name is Victor from the Star Events team, and I'm glad to be your host for the session today. Thank you for joining today's live on web online seminar on all about fertility, steps to conceiving and preparing for pregnancy. This 1-hour session is organized by Star Media Group and supported by Sanford International Fertility Center. It is streamed live on Starbiz Facebook page, so thank you everyone who is tuning in right now. Do share our Starbiz Facebook Live with any of your colleagues or friends who are keen to join. All right, a few quick housekeeping matters before we begin. As everyone dials in to this webinar through different internet bandwidth and devices, you may or may not experience minor technical glitches. So please be patient if there's any. To minimize the risk of technical glitch, all participants are muted, video cam turned off, and chat box disabled by default. But do participate by posting questions to our panel. You may send in your questions to our panelists at any time during the session. On your user panel, click on the Q&A button and post your questions if you are using Zoom, or place it in the comment section if you're watching via FB Live. There will be a short survey at the end, so please, to those who's joining us on Zoom, please do take a few minutes to complete it because your opinion matters to us. For today, bonus for all attendees, Sanford International Fertility Center will be offering couples from this webinar a special fertility assessment package at a discounted price of RM 290 instead of RM 700 until 30th of April 2021, but only if you're registered and attended via Zoom. So please quickly register if you are currently watching via FB Live. Lastly, and most importantly, please engage, learn, and enjoy. Infertility is on the rise, with 1 in 8 couples having problems getting pregnant or sustaining a pregnancy. 40% of couples trying to conceive have male-related issues, while 10% of women will have severely reduced egg reserves by the time they pass the age of 32. Sanford International Fertility Specialist will share on the various causes of infertility, the myth of infertility only occurs among women, the latest in fertility technologies or treatment modalities, and how it can help couples. Personalizing treatment towards infertility in couples. So for this afternoon's discussion, we have the pleasure of having 2 renowned O&G doctors specializing in fertility as our speakers. Dr. Lim Lei Jun is the Medical Director and Fertility Specialist of Sanford International Fertility Center. She graduated with honors from the Manipal Academy of Higher Education, India, and proceeded with postgraduate specialization on obstetrics and gynecology in UK. Apart from her professional accolades, Dr. Lim is the mother of 4 lovely daughters and strives to give back to the community through her active involvement with the SUSI International Medical Association. And also we have with us Dr. Isan Sitamoni, who is the Director and Fertility Specialist from Sanford International Fertility Center. With extensive experience across Singapore, Malaysia, and the United Kingdom, Dr. Isan is no stranger to obstruction and gynecology scene in Malaysia. Dr. Isan is also an active member and former president-elect of the Obstetrician and Gynecological Society of Malaysia, and he has also authored the book Overcoming Fertility, published by MPH Parenting Series. We also have guest speakers, Puan Izura Ashikin, Ms. Anzi Mashikan, and Mr. Madival, who we are extremely grateful to have to be able to spend some time with us today to share their experience, as they actually have gone through fertility treatments themselves. With that, I'd like to hand over to both Dr. Lim and Dr. Isan to begin the session.
Hi, good afternoon. I'm Dr. Isan, and Dr. Lim is here with me. Perhaps before we start, we could tell you a little bit about where we come from. So basically, we are with Sanford International Fertility Center. We are one of the larger fertility centers in the country. We have 4 branches, including in East Malaysia. And last year, we did about 1,300 fresh cycles of IVF throughout our 4 centers in the country. We do like to think that our center is perhaps one of the ones with better technology, and I think that we have the patient load that supports that. I can't see the slides. Okay, Dr. Lim, I'd like to say hello to our audience.
Hi, good afternoon, everyone that's tuning in from Zoom and FB. A very good afternoon to all.
Right. Just a few more words about our centers. I think it's also worth knowing that we have a synergistic partnership with Fertility Associates, which is one of the leading fertility providers in the other part of the globe, primarily in New Zealand and in Australia. So much for who we are. Perhaps a word of what we intend to do this afternoon, ladies and gentlemen. If I haven't already said it, on behalf of all of us, thank you very much for joining us on this Saturday afternoon, a Saturday which is perhaps the first of a long weekend for many of us. What we intend to do in the next 1 hour is perhaps to give you a rough overview of fertility, what are the causes, what are the treatments available, but perhaps most importantly is not what either one of us has to say to you, but perhaps most importantly is that we have guest speakers with us this afternoon who will share with you their own personal experiences. And I think that this is something which is highly uncommon, and we are indeed indebted and grateful to our patients for having agreed to come on board this Saturday afternoon to share their experiences and perhaps some words of wisdom that they may have for all of us. With that, ladies and gentlemen, can I just pass it to Dr. Lim, who will speak to you about what exactly is infertility and what are the causes of infertility.
Thank you, Ethan. Right. So now, before we say what is infertility, I don't really like the word infertility. I think sub-fertility would be more optimal. By the way, what is fertility? Now, in women, fertility means the ability to become pregnant and have a baby. Whilst in men, fertility means the ability to make a woman pregnant. So quite simple. So what is infertility then? Now, WHO defined this as the failure to achieve a clinical pregnancy after 12 months or more of regular, unprotected sexual intercourse. So often when we ask patients, how long have you been trying? They will tell me, we have not been very active, but we don't need to be like active as in timing all the time. But if you really have 12 months of unprotected regular intercourse and there is no pregnancy that has resulted, we will say you probably have subfertility. So how common is this problem? Now, overall is 1 in 10. But if we look carefully, it's actually very dependent on women's age. When the woman is between 30 to 34, it's probably 1 in 7. And when the woman is between 35 to 39, it's probably 1 in 5. And if you are above 40, it's more common, it's in 1 in 4. Now, what it takes to become pregnant? It takes an egg and a sperm. So what happens during normal process? The egg ripens and get released, and during intercourse, the sperm swim forth through a patent fallopian tube. They both meet in the tube. They get fertilized, and day 1, 2, 3, 4, 5, 6, they are back into the womb. So this is how the journey begins. Now, to understand this is to find out why it hasn't yet happened. So we need a normal egg that carries 23 chromosomes and a normal sperm that carry another 23 chromosomes. These two come together We call this fertilized egg that will have 46 chromosomes or 23 pairs of chromosomes as in all human being has. All right. Now, what could be the causes? Now, in the past, women are often takes the blame of not able to become pregnant. But nowadays, it's known that we all carries the same contribution. We contribute similarly. So only male factor is probably 1/3. Only female factor is 1/3. A good 20% will have some male problem and some female problem. Now, about 10%, that means 1 in 10 couple, may pass through all standard testing. Actually, in some series, is as common as 30 to 40% of unexplained subfertility. Now, what could be the causes from a women's point of view? First, the egg is not getting mature, it's not getting released regularly. We call that ovulatory dysfunction. Or she could have blocked fallopian tubes wherein the egg and the sperm does not meet. Sometimes women also have gynecological conditions such as fibroid, endometriosis, and polyps, which can contribute to her chance of getting pregnant. Certain women are born with structural abnormalities of the womb like unicornuate, bicornuate, and Delphis. These can also contribute to her chance of a pregnancy. First and foremost, last but not the least, is the women's age. Now, what about causes from him? Now, although we need only one sperm, but if you have less than normal sperm, that will reduce the chance of conception from the man. And some sperm that are weak, as you can see, they travel a long journey, right? From the vagina up to the tube is a long journey. So if the sperm is not as active, it may get tired out before it can reach the fallopian tube. And the third one, they could be having abnormal shape and forms. And some men may not have sperm in the ejaculate, all right? So there is another big portion of what we call unexplained subfertility. In the past, we used to think that it's probably 10%, but I think it's more, all right? Now, actually, this is a diagnosis made to couples when they pass through all standard testing, wherein the couple will have, the women will have a normal ovulation, regular cycles, will have normal tube, at least one of her tube is normal, and the husband will have a normal semen analysis. But is that all it that it takes to pregnant? No. Unexplained subfertility, sometimes certain other things like age of the women, her ovarian reserve, her egg quality, and the presence of endometriosis, other uterine factors, cervical mucus factor, tubal dysfunction, immunological factors, genetic factors, coital difficulties, or failed fertilization are all possible causes of subfertility too, but they are not being picked up by standard testing. So we clump that under unexplained. So if you look really carefully, there will be some causes. It's not totally unexplained. All right. So now, before I move on to when nature fails, what can we do? Maybe I want to pass it back to Dr. Eason to tell us something more about age of the women and about male infertility. Dr. Eason, back to you. Hello, Eason.
Yep, I'm here and I've got my slide. Okay. Right. So, despite how macho one may think he is, the fact of the matter is that male fertility or male subfertility is a real issue. And I think that that is an extremely important take-home message that I have for everyone today. In the past, as Dr. Lim would have mentioned, many men would just have assumed that there was no issue. And many women would have just accepted that it was entirely their fault. And in fact, even in the clinic setting, you will see that there's often a bit of a blame game that goes on, whereby the couple will each be looking at each other, wondering whether, whose fault is it? Is it my fault? Or
Sorry, can I just interrupt? I think they can't see your slide.
Okay, can you see it now?
Yeah, now it's good.
Okay. Okay. Okay, so that's the blame game that goes on between the husband and wife, okay, both trying to pin the reason for the subfertility on one another. And the fact of the matter is that 40% of the causes of male infertility revolve around a male cause, okay? So that's really, really important to understand that male infertility 40% of the time. Now, the question that most people will ask us is, why is it that there is male infertility? Okay, what are the reasons for infertility in a male? And I think that there can be many reasons why there is this problem. But I think that in all honesty, most of us accept that the most common reasons why there is male infertility is unknown. Okay, so don't be surprised if you are told that male infertility cause is unknown. Okay, but the interesting thing is, how do you actually diagnose male infertility? The answer is quite simple. All you have to do is a simple semen analysis, okay? And how difficult can that be? A simple semen analysis just takes a few minutes of your time, and that's it. So no matter how macho a man may look, the answer is you may still be somebody who is at risk of having a male factor cause for infertility. When you do a semen analysis, what do you look for? There are many, many things that we look for on a semen analysis, but the main things that we look for are the sperm counts, the sperm morphology, and the sperm motility. In other words, do you have enough sperm in the sample? Do they look normal enough? Or are they swimming well enough? Or are the good swimmers adequate? Okay. Now, it's also important to know that when you look at the appearance, because by far the most difficult thing to analyze is the appearance of the sperm. Okay, so this slide basically illustrates the various abnormalities that you can find when you look under the microscope at the sperm. And in the far corner, you have a normal looking sperm, and then you have all the other odd looking sperm. So do not be surprised, because the pass mark is 4%. So if you get 4 normal looking sperm out of 100, then you pass. And believe me, getting 4% is not as easy as it may seem. By far, the majority of people that we see through the clinics will have a 3%, perhaps even a 2%. And sometimes you may find that rare individual who's running around with a 5%. If you do a semen test somewhere and you get a report, and the report tells you that 90% of the sperm look normal, then I can tell you without a single doubt in my mind that that test was probably done by somebody who does not know what a semen analysis is all about. Okay. Now, moving on, just one other thing is the good news. So the bad news is that 40% of infertility is associated with some male factor. That's the bad news. So male factor is real, but the good news is that, remember that when the first IVF baby was born in 1978, male factor infertility could not be helped at all, because if you had problematic sperm, you could not do IVF because you could not fertilize the egg. But fortunately, 15 years later in 1993, along came ICSI, intracytoplasmic sperm injection, whereby you could identify one sperm and inject it into the egg, and then things moved forward to the next level. So it took 15 years from the first IVF baby for reality, for it to become a reality for those with male factor. Even in azoospermia, where there is totally no sperm seen in the sample, we are now in a position, we are able to identify sperm when we do a small biopsy on the testicles to find sperm and use that sperm for ICSI. How things have changed. And of course, lifestyle changes will help with sperm production. We talk about supplements, talking about reduced smoking, and more importantly, talk about reducing the alcohol. We now even use clomiphene. I mean, clomiphene or clomid is something that many of you would have heard of before. We now use clomiphene for men with sperm issues because it has been shown to be quite useful. So take home message, most male factors of fertility can be helped. Now, so we've spoken a bit about how we assess couples who present with infertility, and Dr. Lim has also illustrated to us what the various different treatment options are. Perhaps now would be a good opportunity for Dr. Lim to illustrate to us what the various possible treatment options are. Dr. Lim. Mic on.
So what happens when nature fails? That is why Sanford is here. That is why we are here to help. So remember this, fertility is time sensitive. First of all, how long should you try to conceive before seeing a doctor? Very important. When women is younger than 35-year-old, you can try on your own for a year. When women is between 35 and 40-year-old, perhaps try on your own for about 6 months. If you're over 40-year-old, please go see your doctor. All right. Now, in Sanford, we adopt a problem-based approach. So how is that? First of all, how old is the female partner? How long have they been trying? And any significant gynae pathology that requires surgery before IVF or IUI? And how keen is the couple to move on? So this is largely how we approach. Now, first of all, I want to talk about an overview of what fertility treatment entails. A simple one would be intrauterine insemination. Now, this has got two criteria. Number one, the sperm must not be too little or too weak. Number two, at least one of the fallopian tubes must be patent. That means must be working, right? Must not be blocked. So what we do is that we get the women to perhaps have two dominant eggs through some tablets, fertility pills, and possibly some injections. And when the time is correct, we both couple come back and we perform an IUI. The male partner will then release his sperm, and we will get this sperm to undergo some washing and preparation in the lab, okay, where we concentrate the most motile sperm. All right. Then we inseminate the sperm, this motile sperm, at the right timing into the female's womb. All right. And then we wait for 2 weeks. Okay. Next up, what happens if they need IVF, okay, or ICSI? That usually happens when both the tubes are blocked or when the sperm is very few, too little, or too weak. Then we perform what we call intracytoplasmic sperm injection, where we actually choose a healthy looking sperm and inject them directly into the egg. 1 sperm per egg. Some of them who have very good sperms, but just because of blocked tubes, we will instead perform IVF, wherein we let the most motile sperm make the penetration on its own. Okay, so once this embryo has been created, either from IVF or ICSI in the lab, okay, they then will be cultured in the incubator to embryos at day 2, day 3, day 4, or day 5. Okay, day 2, day 3, or day 5 embryo can then be transferred back to the women's womb, and we will have to wait for another 2 weeks for them to implant. Now, not everything is settled by IUI IVF. Sometimes there are certain significant pathologies such as polyp within the womb, fibroid within the womb, such as this, as you can see. They may require surgery before an embryo can implant. So this is the same patient where we have a polyp, and the next picture is when the polyp is clear. You can nicely see the 2 openings of the fallopian tube. Now you may ask, why is one picture appears more reddish than the other? Now we know that blood doesn't reflect light very well. Once that is being removed, you can see that it's a very clear picture. Similarly, on the right, this woman has a fibroid within the womb. After clearing, 2 months later, you can see a very nice cavity, and she conceived naturally on her own without having to go through IUI, IVF. So sometimes obvious reasons like this may have to be dealt with surgically. Some other time, they may require laparoscopic surgery like endometriosis, a blocked swollen tubes, or fibroids. Okay, so after settling all these problems, sometimes they can conceive on their own. All right, so that is largely an overview of what we can offer apart from fertility treatment. Certain fertility surgery might help as well. So I'm going to pass back to Dr. Eason to talk to you more about women's age. Dr. Eason, back to you.
Yes, thank you, Dr. Lim. So I now want to speak to you about what I think is possibly one of the most important things that I'm going to say this afternoon. What is the most important determinant of your fertility potential? What is the most important determinant of your fertility potential? And that is age. Okay. Now, many of us are unaware that our peak fertility is at the age of 22 to 23. Okay. And I can just remember when I was 22 or 23, there were many other things that were more important in my life than the thought of getting pregnant. But there you are. Human fertility being what it is, peak fertility of the human female is between the age 22 and 23. Now, it is important to remember that we are born with a fixed number of eggs. Okay? And over the years, from the time of birth, the egg numbers will continue to decline. And at a certain point in time of age, you will find that the fertility or your chances of getting pregnant will become less, and there will come a point in time when we are no longer able to become pregnant. And I think that we have to be very clear about what these timelines are. So the concept that I'm speaking to you about is called ovarian reserve. So what is ovarian reserve? The ovarian reserve is the total number of eggs that you have remaining in your ovaries. If you want, for want of a better way of describing it, it is your ovarian egg bank account. Okay, it's your ovarian egg bank account, and we always have to be clear about where we stand in as far as the ovarian egg bank account is, so that we know what our chances are of getting pregnant. You will be surprised the number of times that we've had women coming through in the late 40s who think that just because we have our normal menstrual cycle, which is relatively regular, that the chances of getting pregnant are still there. But the truth, unfortunately, is quite far from that. Okay? So remember that at the age of 20 weeks of gestation, in other words, when you were 20 weeks in your mother's womb, you had about 6 to 7 million eggs. And at birth, there were only 1 to 2 million eggs left behind. Egg numbers will not increase. At puberty, there are about 300,000 to 500,000 eggs, and this loss continues until the menopause. Okay, and at the point of menopause, there are only a few hundred eggs remain, and therefore chances of getting pregnant are quite negligible. In fact, if I dare say, quite impossible. Now, many of us believe age equals to fertility chances. Now, everybody knows that, everybody believes that, even, you know, that auntie that lives next door to you will say, listen here, your age determines the chances of getting pregnant. This is usually true, but not always, because 10% of women in their early 30s will have egg numbers that are so reduced that they cannot conceive. So the question, of course, is, do we all start with the same number, or do we start with the same number but the rate of decline perhaps differs between people. Okay, that may be what differs or differentiates people. Okay.
Ethan, slides, please.
Okay. Why can't just be yeah. Can you see that? Yeah. Okay. Can you see the screen now? Yep. Okay. So I think that it's important to know that in addition to the fact that only 10% of women, 10% of women will have reduced egg numbers so serious that they are unable to have children even in their early 30s. It's also important to remember that there is a very clear relationship between age and egg abnormalities. Okay. Now, the rate of egg abnormalities will increase with age. The rate of abnormalities in women under the age of 35 is only 10%. By the time you age, your age has reached 40, it is about 30%. At the age of 43, it is about 40%. And in women who are above 45 years, it is said that almost 100% of the eggs may have abnormalities, and therefore not surprising that embryos that they may produce have abnormalities, and therefore pregnancy becomes quite difficult. Okay, so so much for the relationship between age and fertility chances. Okay, now perhaps now we can have a quick look at what the recent advancements are with regards to fertility treatment. Okay, and Dr. Lim will take us through some of that. Yes.
Thank you, Ethan. All right, so Dr. Ethan just now mentioned about egg abnormality and hence embryo abnormality. Now, are there any recent advances to help us understand this bit a little bit more? Definitely there is. Today, we are very fortunate we can have this technology called pre-implantation genetic testing, which means before we put back the embryo, we are able to determine whether the embryo that we are going to transfer is in fact chromosomally normal or not. How do we do that? Now, this is further divided into pre-implantation genetic screening or PGS and pre-implantation genetic diagnosis or PGD. Many get confused between the two. No, to simplify this, if the couple is not known to carry any genetic problem, by virtue of age, they want to screen for age-related chromosomal abnormalities such as Down syndrome, then they can go for PGS or pre-implantation genetic screening. Whereas if a couple is known to carry certain genetic disorders such as thalassemia or cystic fibrosis, they then will have to go through what we call pre-implantation genetic diagnosis. That means we are specifically looking out for certain specific genetic problem. All right. So as Dr. Ethan has clearly illustrated, and that is one of the foremost important factor of an IVF success is because the percentage of abnormal embryos does increase with age. You look at the graph here. Now, although under 30-year-old is not free of chromosomal or embryo abnormalities, but they are significantly lower. At 29-year-old, probably 20% are abnormal. Of 29-year-old, if you were to make embryos out from 29-year-old women, probably only 20% that are not normal. But that ratio is being reversed at 42-year-old. It's as high as 80% of embryos are abnormal at 42. And as Dr. Ethan has illustrated, by 45-year-olds, nearly 100% are not normal. So abnormal embryos are the leading cause of why an IVF does not succeed, because they fail to implant, they miscarry, or if they bypass these two natural gates, so to speak, the baby that is born may carry some abnormal chromosomes, such as Down syndrome. All right. So these are the embryos from a 30-year-old and a 40-year-old woman. Okay. You can see they equally have the equal number of embryos. The green are the normal ones. The red is the abnormal one. So at 30-year-old, probably 1 in 6 that are not normal. At 40-year-old, it is 1 in 6 that is normal. So this explains why the chance of pregnancy for older patients is much lower. However, if we are able to identify the normal embryo between these two women, like 30-year-old, we have so many, we transfer one. And in this 40-year-old, we also transfer this one. Now these two ladies have the same percentage of success. Okay, so it's not the womb, it's the embryo. Okay, how we do that is that this is a blastocyst, which is a day 5 embryo. We take out about 5 cells from the trophectoderm, which are cells that are destined to become placenta. Okay, we then run some tests on these cells, what we call pre-implantation genetic testing. Then we identify the normal embryo and transfer back to the womb. Okay, so what are the benefits of PGS? It has higher implantation rate, less abnormal pregnancies. We can safely have single embryo replaced, and that reduces the chance of multiple pregnancies, which are known to be high-risk pregnancies. And it can decrease the time to pregnancy and increase cost effectiveness. So who would benefit from PGS? Advanced maternal age, that is more than 38. Recurrent implantation failure, that means you have had 2 failed embryo transfers or more than 4 embryos replaced but no success. Recurrent miscarriages, or it can be done as a routine screening. All right. So apart from PGT or pre-implantation genetic testing, these days is a norm that we culture our embryo in time-lapse incubator in Sanford. So this is how the process works. You can actually have a video of how your embryo develop. So here are the wells where the eggs are being placed. These eggs we have undergo IVF or ICSI. Just watch them, right? So this is appearance of 2 pronuclei the next day, and the cells divide to 2, 4, day 2, and they further split to 6 to 8, day 3 embryos. Then this is a fast pace of development, day 4, and coming to day 5. You can see beautiful blastocysts have formed. All right. So from these 12 eggs, these 2 did not divide or did not further develop. This one further developed, but it's not a very good grade blastocyst. Okay. So how do we do it? From all these 12 eggs, these 3 are now being excluded. Now, how do we know amongst these how many are normal? Okay, so if this woman this couple have thalassemia carrier, first of all, we put the first filter through, okay, check for their PGD, and we found out that these 3 are affected, meaning these 3 embryos carry thalassemia. All right, these are carrier. They can still be used, but they carry the thalassemia gene, but they are not affected, and these 2 are unaffected. So then you screen these 3 out. Okay, then you put on the second filter to look at their chromosomal makeup, and you can see that these are all normal chromosomal makeup, but this is not normal. So this is again out. All right. So from all, now we are left with 4. Okay, 4 that can be used. So which one will be first? Of course, unaffected normal one first. All right. So these 2 first, then carrier, the embryo that carries the thalassemia gene, but they can be born normal, but they could pass it to their next generation, you see. So our first choice will then be the unaffected one. You see, when we use time-lapse or cariomapping PGD and PGT if necessary, PGD if necessary, we are able to exclude embryos that we do not use. So we call this deselection. So this is how we can improve the chance of pregnancy. So that's all from me. Isan, back to you.
Right. Thanks, Rejun. Now, can you see this slide? Right. Can. Okay. Can you see the slide? Okay. Yep.
Yes.
Yes. Okay. Right. So fertility treatment should not be personalized. Should be personalized. What do I mean by that? Now, it is historically, IVF has been rather standardized in many ways, and I think that sometimes now patients or couples may find themselves ending up doing IVF on what is sometimes seen as an IVF assembly line. And I think that we need to be aware that IVF, for the matter, even fertility treatment as a whole, but perhaps IVF in particular, is not a treatment whereby it is one size fits all. Okay, what do I mean by that? Now, before you even start, the question that we should ask ourselves is, are you actually ready? Okay, and what do I mean by that? Have you, as a patient, before starting IVF, been optimized? Optimized in what sense? In the sense of nutrition. Have you been taking your supplements to ensure that you are nutritionally optimal for starting fertility treatment? How about weight? Has weight been optimized? You do know that above a certain body mass index, the chances of getting pregnant become much less. In terms of lifestyle, have the so-called bad habits like smoking and alcohol been reduced to an extent? If you have polycystic ovaries, have you been put on glucophage, which has been shown to improve outcomes and reduce miscarriages? Has all the appropriate investigations been done, perhaps to exclude thyroid and diabetes? Okay. Now, beyond that, do you have you had a previous cycle elsewhere without success? And this information is quite crucial. Why? If you've had a previous unsuccessful cycle elsewhere, and the information that you would have gleaned from that cycle is extremely crucial. What protocol were you on, and what stimulation medication was used? What dosage were you on, and what went wrong? To have had a cycle which was unsuccessful in the past, and to have not learned anything from that, I think is quite unfortunate, because learning from a previous failure may be the key to your current success. Okay. And if you're starting off an IVF cycle, then what kind of protocol would you use? A long down regulation versus a short? Not everybody is the same. We know that some patients, especially those with adenomyosis, those with endometriosis, would benefit from a long down regulation cycle versus a short cycle. Perhaps if you have a low AMH, a low ovarian reserve, then a myostimulation protocol would be better. How about the meds that they're going to use for stimulation? The majority of us certainly will respond in a similar manner. Yes, I agree, but not all of us. Okay, some of us will not respond in a usual manner, and therefore these are the people who need to be singled out, and perhaps a particular kind of medication may be preferred. And in terms of dosage, has an anti-Mullerian hormone level been done? Receptor insensitivity is not uncommon, so beware. And how about an antral follicle count? There are good cycles and there are bad cycles. And perhaps if this is a bad cycle, this may be a cycle that you may want to forego. So these are the kind of things that we should be looking at before somebody starts an IVF cycle, because then you would be actually individualizing or personalizing the treatment for that particular patient. Because remember, it is without doubt that fertility treatment is an emotional, it is a logistic, and a financial roller coaster. Knowing what your issues are and understanding the rules of what I often call as a numbers game will help us all cope better. It reduces stress, and most importantly, it keeps you and us all sane. Okay, this is ultimately the road to success. Right, ladies and gentlemen, that is perhaps the end of the short presentation that we have. We now have questions that we will answer, but before that, we will ask our guests for this afternoon. We have Puan Azura first to go. Could we ask Puan Azura to switch on her camera perhaps so that we can see her? Yes, Puan Azura, yes.
Okay. Hi. I'm Izura. Sorry. Okay. Hi, I'm Izura binti Muhammad Jamil and I'm from Banting. Thank you for inviting me for this sharing session to share my experience and journey going through the IVF process. Actually, we decided to do the IVF process lepas kami berkahwin 2 tahun. And why I choose Sanford is because I got a good recommendation by a doctor in private clinic. And we have been TTC for 2 years with Sanford and I under Dr. Lim. We have been through 4 attempts of IVF, which means we have been experiencing the 4 times of embryo transfer. And from 4 transfer, 2 of them were success and another 2 will fail. And to be honest, there is a lot of sweat, tears, up and down yang kami lalui selama 2 tahun. And we started the process and the procedure on May 2017. And I got pregnant on October 2017 on the same year, which is from second transfer. Surprisingly, I really happy. We are really happy on that time. After we got the failure on the first attempt, if you can see this the result. And when Dr. Lim showed us the result, Dr. Lim told us that maybe kami akan dapat twin. So, but still not confirmed yet because we didn't do the scanning. And after 2 weeks, we done for the first scanning, and surprisingly, what Dr. Lim told us before is correct. Kami dapat kembar, but bukan 2 tapi 3. You can see here the first scanning. First scan yang kami buat 3, and I believe most people impikan untuk dapat kembar, tapi tak terbayang untuk dapatkan 3. Seriously, we were speechless on that time, and really happy, but at the same time agak merisaukan after Dr. Lim told us multiple pregnancy mempunyai risiko yang sangat tinggi compared to single pregnancy. But thanks God, sepanjang check up, all my babies grow well, and happy to hear their heartbeat for the first time. And I see their movements masa buat scanning. I think is satu momen yang sangat seronok, happy sangat bila dapat tahu kami dapat triplet. But unfortunately, kegembiraan tu hanya sekejap sahaja. On 20 of February 2018, which mean a week after I have done a detailed scan in government hospital, I got pregnant loss due to cervical insufficiency. And seriously, we were really shocked that news. All my babies can't survive and all gone. And seriously, masa tu memang I tak boleh bayangkan. I can't believe actually. And I hope my babies still alive at that time. And can you imagine masa I delivered my babies, 2 of them actually still alive, but we can't do anything. Disebabkan usia kandungan, usia baby tu baru 21 minggu, and sangat-sangat mengganggu fikiran, sangat-sangat mengganggu emosi. And for the first 2 weeks, I cried every night, every day, and I can't sleep well. I teringat all the moments with my babies masa tu. And satu lagi yang membuatkan I was struggling with my emotion because ada baby dalam rumah. I got pregnant loss on February. My sister-in-law just delivered her baby on January, and her baby dijaga oleh my mom. And can you imagine, I berpantang without my babies, tapi ada baby dekat situ, so it's really hurt lah, and sangat-sangat mengganggu emosi every day actually. And I can't even see that baby. Kalau dia menangis pun I biar je, that's not my baby. So I think it take masa yang agak lama juga untuk recover myself, my emotion. And after few months, if not mistaken, on August 2018, I come back to Sanford. I met Dr. Lim. I told Dr. Lim I want to try for the third embryo transfer. Even though at that time I'm not confident enough to do the third, but I still want to do because I rasa macam selagi I tak dapat, I tak puas hati. And masa tu I still have a few frozen embryo. That's why I proceed to do the third. So but unfortunately the result negative, and I got once again I got failure. Seriously, masa tu I totally give up. And I'm really tired. I don't know. I keep asking to myself, why is happened to me? Why it's so hard for us actually to get a baby, at least a baby. So start daripada situ, I don't want to think about baby anymore. But selepas 2 bulan, after 2 months or 3 months from next, I can't remember. I don't know daripada mana dia datang. I just feel that I got a new life. I got a new strength. I got a new spirit. I don't know daripada mana dia datang. And before I discuss with my husband, I drop an email to Dr. Lim, telling her that I want try for the fourth embryo transfer. And masa tu I told Dr. Lim I'm ready, whatever result yang akan keluar. And I rasa masa tu I feel better, and I want to do the fourth transfer, and that will be the last at that year. So on early November we proceed to the fourth transfer. This is the moment actually, and this a few days before we go through the fourth transfer with Dr. Lim, and thanks God, the result is positive. Seriously, speechless, and rasa masa tu, yeah, we did it. Kami dapat kejayaan kali kedua and got pregnant for the second times. And kali ni memang kami sangat-sangat berjaga-jaga, and Dr. Lim always told me, please don't go travel and then go jangan buat anything yang berat, and duduk rumah sahaja. Memang kami jaga betul-betul. And thanks to God again, my baby grow well, but this time is a single pregnancy, and ini adalah lelaki. Previously all girls, and kali ini adalah lelaki. And you can see here my baby, okay, grow well and sangat-sangat happy. Kali kedua dapat dengar heartbeats my own baby, and I dapat rasakan pergerakan baby. He always kicking to my room. Sangat-sangat happy. And on 5 August 2019, and that was my lovely boy was born on 40 weeks actually, 3.5 1 kg. Seriously, just after deliver my baby, I menitiskan air mata disebabkan I rasa syukur sangat-sangat apa yang kami buat selama 2 tahun, it's worth. Sangat-sangat berbaloi dan we did it. So I mengucapkan terima kasih to everyone yang participate and be a part on my journey, especially Dr. Lim and his team. Okay, give your support, your assistance, and always contribute your effort on this journey. I'm really appreciate Dr. Lim. And this my lovely baby, time ni masa 5 bulan, 5 months, kami buat photoshoot. So I hope my journey will inspire others, and don't give up. Actually, don't give up. Please don't give up. You may try until you dapat apa yang you impikan. So this is my family, my happy family. Now my baby dah 1 tahun 6 bulan. I really love him so much. And last but not least, I want to say to Sanford, yes, Sanford, we already conceive our dream with you. Thank you so much. Done. I'm done.
Thank you, Izura.
Okay.
Thank you for that very moving sharing. I mean, she is one patient that I see immense strength, and I really salute to her for not giving up, for believing and trusting herself and us. Thank you so much, Izura.
Yeah.
We are waiting for you to come back for the second one. Okay.
For the file transfer.
Can we now invite our guest, Mr. Mael and his wife, Enzi? So they have a tale to share with us as well. Quite a journey. Come, Mr. Mael and Enzi, can we have your input, what your thoughts are on what your journey was like, and so on. Come.
Hi, I'm Enzi, and this is my husband. Today I would like to share my journeys during pregnancy. So we direct lah. So after 2 years of marriage, we tried to conceive, and we went to a hospitals and see the doctors. And after discussions and everything, the doctors suggest us to have surgery and proceed for after the surgery. Then they asked to proceed for the IVF. So we went for the IVF for the first time. We do follow the process and everything, and comes to the results, and it is fell. Yeah, that time I was down and sad, but I said to my husband that I want to do for the second time. Then my husband said yes. So we go for the second time for the IVF. We do the same process, and everything, and comes to the results again, it's fell again. That time my feelings not the same like the first time. I was so angry, I was so sad, I was so down, I was so insecure. I have everything. Then I told to my husband, that's it, I don't want to do again. I said, I want to stop. I said. Then my husband didn't say anything. I just totally didn't do anything. So I tried to calm down myself, do searching, do research, and then I found Sanford. That time I said to my husband, I said, can I do for the 3rd time? Then my husband said, yes, you may. So I go. We went to the Sanford. Then we went and see Dr. Isen that time. We tell Dr. Isen our expectations, that we already fell for second times and what we want. Then Dr. Isen suggest and tell to have a 3rd IVF. So we go for it. We do the process. And then after that, after the 3rd, on December, I got a Christmas gift. I get the gift. And at first, I don't want to. I do the test first. I didn't tell my husband and everything. But during the seeing the doctor, I cannot what do you say? I cannot hide my emotions and feelings. Then the doctor said, "You already know, right?" You said, "Yes, I already know." And guess what is? I get twins. I'm so happy. I'm jumping, I'm jumping, saying the doctor. I'm very happy. I'm so happy. Then we go for the pregnancy process. But during the pregnancy, I had a heavy bleeding, which that time I'm so panicked. I call everyone. I cried. I said, "Am I losing my baby? What gonna happen?" I said, I give praises to my husband. I said, "Please call Dr. Isen. Please call Dr. Isen." I said, "I want to see him." It is a midnight, no. So that time I'm so sad and panic. So on the next day, my husband bring me to see Dr. Isen, and Dr. Isen said, "No, nothing to worry. Everything is okay. The babies is healthy, sehat. Don't worry, don't panic," and teach me everything. But first mother is, I think, is like that. You have the panic, I think, more than 100%. So that's it. Then after that, we go for the process, having the symptoms and everything until the delivery process. We went for it, and it went well, and I got my cute baby and healthy. So today I'm gonna share to you my baby's pictures where I had it. This is my newborn baby. The left is the first one, and the right is the youngest one.
Can you guys see the slide?
Yes, very nice.
Okay. No, this is when you're born. I remember bringing it to Dr. Isen, showing to them, and this is this what 6 months.
This one is a 6 months.
Monitoring the babies, it goes to the wife lah, so it's not much. This is 6 months. This is a year old. This is 1.5 years, and they're really causing havoc. Now, my take on the whole journey was, it was a lot of confusion, panic, sadness, disappointment, surprise. I think the ending was quite a fantastic journey where you have amazing happiness and also joy. And to see that the whole journey, it was an emotional roller coaster. And how Dr. Isen always says that if there's no pain, there's no gain. You definitely will go through the torturing process, emotional challenges. The only thing you should keep yourself is never get all those negativity get to your head. You must always be calm, strong, and maintain. And I think the composure is very important, and I think perseverance is very, very relevant here. You should not give up. Well, I mean, I had my emotional challenges, which I always contain to myself because, you know, my wife's already in that aspect. You should not, you know, give her more pressure on that. So you should be a pillar to support her in all the way that she wants. No doubt, intensive research was done by her herself. I would have contributed probably 10 or 20% of the effort. But then again, she never gave up and she continued all the way. And I was very supportive of what she did. And we are very happy to see both these kids now causing the house upside down and also so much of terror in the house. So thank you very much, Dr. Isen. You made it happen. And obviously, we're looking forward for the next one because he still owes us one that's still in your facility. So we'll come back to that after everything have settled down.
I think upon Izura, Anji, and Mr. Mayer, I think if there's one thing that both of us, Dr. Lim and myself, will agree, definitely the patience and persistence and the resilience that you all have shown, I think is amazing. Okay, when we sit on this end of the table, we also understand that it is not easy. In fact, I think we all agree that one of the hardest things for us to do is to tell somebody that they're not pregnant. Okay, it is not as easy as one thinks. Okay, because we get sucked into that emotional roller coaster, and it's very difficult. And I sometimes, I get irritated, and I tell my nurse, I say, I just going to let you tell the patient, because it sort of, it keeps us away, but you can't do that, So we get, sucked into the whole thing, and we also go through the same emotional ups and downs, just as our patients do. And it's quite draining emotionally. So congratulations to all of you. I think you all have been rewarded for your own hard work and persistence and resilience. And your husbands have given you the support and the patience. And I think it's just amazing. Lejun, what do you think? Do you agree?
Definitely, I'm not sure if I were to put in their shoes, if I have that strength or not. It's really not easy. Like Ethan say, the beta HCG day, oh my God, our heart goes like 200 and or whatnot. It's tough. It's no easy job.
And sometimes the person who bears the brunt of all this is none other than the MLT who takes the blame. Nothing else to do with anyone. But kena bamboo from all of us when the news is not good. Right. Okay. So thank you guys so much. But please stay on because I'm sure that some of the participants may have some questions for.
Yeah. I think some I read out this question here. Maybe NZ and Izura, maybe if you would like to share with the listeners, as we have a question here. If it is okay, can Puan Izura and Puan NZ share what was the reason that you not conceive naturally? If you are willing to share, I mean, maybe they want to find some correlation. If a similar story or similar reasons, maybe there is a source of strength to them if you want to take on these questions. Over to you, Izura. You want to go ahead first?
Okay. For my side, actually, there's a medical issue on my husband, actually. That's why we tend to do naturally. And if you still remember, Dr. Lim, firstly, you suggest to do the IUI first before we proceed to the IVF. But we decide to do the IVF. We proceed the IVF after we know the percentage of the success rate is quite low compared to the IVF. So that's why we proceed to the IVF. Sebab kami tak nak buang masa, so we just proceed to the IVF. Tak nak buang masa, tapi still 2 years to get a baby.
Yeah. This is the realistic thing. Many sees that, okay, I get this date, I go there, I'm going to get they already start, when will my baby be born? I mean, as much as I want you to be on the positive side, but really I don't want to drop your expectation. I mean, at the best case, I mean, if Isa will agree with me, half the time you're breaking bad news.
Yeah.
So, I mean, it's realistically, if your expectation is so high, you're going to drop so much. But doesn't mean that you want to be negative, but just pull yourself back and look at it as a whole. You see, Izura, she has many embryos, and of 4 attempts, she replaced 6 embryos, and she has 4 babies from there. So sometimes the not successful, you may make it the second goal. So, we want to be realistic, not pessimist or not over optimist, because you want to have that buffer. All right.
So, ladies and gentlemen, we have a total of 56 questions that have come in. I can promise you one thing: there's no way that I can finish 56 questions in the first 15 minutes. But I think we can agree, Lejun, that we will go through maybe 15 of them. If we can. Perhaps I start. We can just go through them in alternate fashion. The first question, ladies and gentlemen, is for blocked fallopian tubes. Can it be checked by ultrasound scan only? And I think that the correct answer to that is that you actually cannot assess blocked fallopian tubes by doing ultrasound per se. In other words, when you do a normal ultrasound scan, when you try to look at the womb and the ovaries, central follicle counts, so on and so forth, you cannot actually check the patency of the fallopian tube. However, there can be some telltale signs. For example, if the tube is blocked and there is fluid that has filled the tubes, in other words, there's something called a hydrosulfings, then that hydrosulfings may be seen on the ultrasound. There is a tubal patency test that can be done using ultrasound, and that is called a ultrasonography, which is HICO-C, but that is not a normal standard ultrasound scan. Okay, so the simple answer is no. The next question, perhaps, Dr. Lim. Why do you want to try the miscarriage?
Oh yeah. Why do miscarriage occurs? What is the best method to prevent miscarriage from happening given that the fertilization has taken place successfully? Now, the most important cause of either failure to implant or a miscarriage is embryo abnormalities. So one of the ways, if there is recurrent miscarriages, we want to go and check whether the embryos are normal or not. We may not be able to do that after a miscarriage all the time. Okay, of course, we can send the product of conception for checking of karyotyping, but it may not be possible all the time depending on the stage of the gestation. Now, fertilization happens, it does not guarantee a normal embryo. As I have showed in the previous slides, we sometimes need to do pre-implantation genetic testing to find that out. All right. So there are other causes for miscarriages as well, which we of course need to screen through and exclude after excluding that the embryo is normal, such as immunological factors, antiphospholipid syndrome. So these are the other causes. Next.
Okay, so there's a question here that says, which I think is quite interesting. Even after doing everything right during the fertile period, why am I not able to conceive? So this is what we're trying to say. I mean, you try, you do it. I mean, how wrong can you be? You know, so you try it in the most appropriate time of the month, and you try it month in, month out, and it doesn't happen. And that is exactly what the definition of infertility is. You are trying and it doesn't happen. Okay, so a couple that have been trying consistently for 12 months, if she is under the age of 35 and not able to conceive, is defined as a couple that has infertility. And then you go to the next level. What is going on? What are the reasons? Okay, and remember, as Dr. Lin mentioned earlier, there's a 40% chance that all the tests that you do is not going to show anything, and therefore you're going to be labeled as having unexplained subfertility. That does not mean that there is that whatever is going on is so strange and unusual. No, it just tells you that perhaps that something that's going on may not be so easy for it to be demonstrable. Okay, and a good example is always failed fertilization. The egg and the sperm meet, but they do not become an embryo. How do you show that? Okay, short of doing IVF and showing it, you can't. So and they get lumped into this unexplained group. So don't get too upset if you have been trying and it hasn't happened. Okay, because infertility or subfertility is common. Okay.
So we have the next question is that after getting positive on ovulation kit, what is the ideal timing to try for pregnancy? What ovulation kit tells you is that there is a surge or a peak of the hormone called LH hormone, and that typically rises 12 to 24 hours before the ovulation. And so if you have a positive test, the best time is on the day of the positive and the next day. I hope that answers your question. Right.
So there's a question here about what gives you a higher likelihood of success, IVF versus ICSI. Now, just to recap, once you retrieve the eggs when you do IVF, there are two ways of fertilizing the egg. Okay. Now, conventional IVF, in the way it was first described in 1978, is you have eggs and then you mix them with some prepared sperm, and then you leave them overnight. You come back and have a look at them tomorrow morning after 16-18 hours to see how many of the eggs are fertilized. That's it. That's conventional co-culture, conventional IVF. ICSI, on the other hand, is when you identify, when the embryologist, the lab scientist, identifies one sperm under the microscope and injects that sperm into the egg. Okay, intracytoplasmic sperm injection. Now, the theoretical benefit of conventional IVF. So what is the biggest problem with conventional IVF? What is the biggest problem about leaving the sperm to to do its thing with the egg. The biggest problem is that in up to 50% of the time, nothing happens. You put the sperm with the egg, you come back tomorrow, and they're still looking at each other. Nothing's happened. Okay, and that is the biggest problem: failed fertilization. ICSI, on the other hand, gives you a much better fertilization rate, and that is the advantage of ICSI. The problem with standard conventional IVF is that if there is a sperm issue, fertilization will not happen. Okay, so even with normal sperm or sperm that passes most of the normal parameters, you can expect a very high failed fertilization rate. Okay, and if the sperms have issues, it's just not going to happen. So ICSI gives you a much better fertilization rate. So coming back to the question, which gives you a better success? In if you have conventional IVF and there is fertilization of the egg and you do get an embryo, you would intuitively think that the embryo quality that you produce with conventional IVF would be better than those embryos produced by ICSI, because it sounds so right, so it sounds so correct. But beware that the evidence that supports that is not that strong. Okay, so the truthful answer is maybe an IVF embryo may be better, but beware that the fertilization rates may leave you disappointed. So it's a trade-off.
We have the next question here. How can a woman know if she had fibroid cysts when not having pain during menstruation? Now, this is not difficult. Every gynecologist have a scan, and fibroid and cysts can be easily picked up by a good pelvic scan. All right, and try to get a vaginal scan done. A good pelvic scan will be able to diagnose fibroid and cysts as small as like 1 centimeter.
Okay, so this is a difficult question, but I will try to give my 2 cents worth, and perhaps Dr. Lim may also want to chip in. This is the synopsis of the story. I have performed 2 IVF treatments in 2 different centers. Both times we did not proceed to embryo transfer as we had high embryo fragmentation. May I ask what causes embryo fragmentation, and also how could you help me? My husband has had stage 2 testicular cancer in 2015 and underwent chemotherapy of 1 cycle in 2015. He has sperms, but they are poor motility, morphology, low counts. And I was diagnosed as atypical PCO. Please advise. So basically, in a nutshell, this is a couple that has undergone IVF on 2 different occasions in 2 different places. Okay, but importantly is that the issue is poor embryo quality. Okay, on both occasions, it's poor embryo quality and therefore no embryo to transfer. So the big question is, why is my embryo quality poor? Is it because of me or is it because of you? Okay, and that's a very common situation that we all face when we have an embryo quality problem. Is it because of the egg or is it because of the sperm? So again, now we have a problem with embryo quality. Is it egg or is it sperm? Or it could be both. It could be both. So in this particular circumstance, we don't know how young this lady is to have some indication as to whether or not there may be issues with the egg. But we do know that it is very possible that the sperms have issues because the husband has had some chemotherapy in the past, unfortunately, and the sperms have been known to have poor motility, morphology, and low count. So my money here is that there is definitely contribution from the sperms to the poor embryo quality. Okay, and whether or not the eggs are also contributing to the issue, we don't know. Okay, they could or they may not. More importantly is how do we move forward from here? So now this is where it becomes a bit of an issue, because number one is the sperm quality going to improve with time as you move further and further away from the chemotherapy that you had on 2015? May or may not, we don't know. And number two is, I'm sure, of course, giving supplementation is without doubt. Of course, we will try our best and give supplementation. The third thing, of course, is there value of doing a testicular biopsy to see whether the sperm which you find within the testis, rather than the ejected sperm, is of any better quality? Very contentious, okay, very contentious. Dr. Lim, your thoughts about this?
I totally agree with Dr. Eason. When we have a poor embryo, it's very difficult to tease out whose problem is it. You need both, right? They both contribute similarly. Obviously, we have had a good embryos even from sperms that are very low count, very low morphology, provided the eggs are okay. So one have to compensate for the others. If both are not good, then sometimes things like this can happen. Now, we want to see what is changeable, what is not changeable. Now, the sperm, like Dr. Eason has mentioned, taking supplementation and maybe trying to possibly think about surgically retrieve sperm, would that help? And women's why, whether changing her protocol of stimulation, giving her supplementation, all that would help or not. These are all many questions that we need to answer. So yeah, no easy task, but we need to sit down and really dissect into their past. Like the women, how can we stimulate again? How we want to modify the stimulation? Often than not, we see that sometimes they go through different stimulation protocol. The outcome can be quite different. So that is what changeable. Now, by delaying her another 1 year, that is definitely doing no good because the eggs are just going to go older. So how we can modify, and certain things we cannot modify, but we have to make do with whatever we can. So I don't see that I can have more to add to Dr. Eason, perhaps just that. If you have anything to add on?
Victor is switched on his camera, so I think that's an indication that we haven't got much time to go.
Okay.
One question, maybe Dr. Lim can take one last question. I'm going to pick an easy question because there are some very difficult questions on this list. Okay, so I can roughly tell. I think we can roughly tell where some of you are coming from, and I feel I feel for you. I feel for you. The easy question I'm going to pick is: I am considering to undergo IVF. Can EPF money be used for such a procedure? Yes, you can. Okay, so that's my easy question. Okay, Victor, how long more do we have?
Actually, we've already gone over time, so maybe what we can do is we go straight to the takeaway.
Okay.
The piece of advice from everyone. Maybe we'll start with you, Dr. Eason.
Okay. So my take-home message is actually quite straightforward. I truly believe that at the end of the day, fertility in every sense of the word is a numbers game. Okay, and how do we play this numbers game? It's more eggs, more embryos, better chance. Okay, and we all know that the relationship between egg numbers and age is real, and therefore the earlier you get going, the better your chances are. Age is everything. That's my take-home message.
Thank you, Dr. Eason. Can we have something from Mr. Mal?
Well, after failing twice and going for the third time, you should just take it as nothing should stop you from getting what you want. I think that's the thing.
Miss Anne? Yeah?
Yeah, that's about it.
Anything from you, Miss Anzi?
I think they already wrapped up for me. That's all.
Maybe a piece of advice, that's all. Yeah. Okay, thank you very much. Zura?
I just want to say in short, don't give up. That's it.
Right, thank you very much. Dr. Lim.
So these are all our careers. Okay. Yes. Now, if you listen to our talk, there's so many technology and so many things. I just want you to remember these two things. To forget about what all the tests and DNA fragmentation, that's so hi-fi things. Two important questions you ask yourself. Like I say, fertility is time sensitive. Two questions only you ask yourself. How long have you been trying and how old the woman is? I think this two is enough to put you into the proper plan. Don't wait further. Sometimes we diagnose, tell them to do ICSI, and they waited and waited and waited. Another 3 years has passed. The sperm stay the same, but the woman is 3 years older. Okay, that's not, they're going to go through the same IVF cycle at a much reduced success rate. All right, so two things if you take home with you: how long have you been trying? Number two, how old have you been? Enough to push you forward, or you think you can wait for some more time? All right.
Thank you so much, Dr. Lim.
Thank you.
So thank you very much to all our speakers, predominantly Dr. Lim and Dr. Eason, along with our guest speakers, Puan Izura, Ms. Anzi, and Mr. Mail, for the dialogue today. I'm sure that our audience had a better understanding of what fertility is about now. So before we end, please help us complete the evaluation poll that will appear on your screen now. And once again, thank you everyone for joining us today. We hope that you have gained valuable insights on fertility. And as a bonus, Sunfed International Fertility Center will be offering couples from this webinar a special fertility assessment package at a discounted price of RM 290 instead of RM 700 until 30th of April 2021. But only if you're registered via Zoom and attended via Zoom. We've actually put in the registration for the Zoom online. You can actually check on that, and you can still register so that they can actually have your details. So thank you very much to everyone. Thank you, and do stay safe.